So officially, hello everybody, and thank you very much for joining this amazing gathering. I'm very proud to say that this gathering is actually a follow-up of a previously initiated work with Asian Pacific Endodontic Confederation, but this time actually it is much hotter because we have our Latin American colleagues that create this atmosphere for us, and with the support and initiation of Mexican Endodontic Society, which followed by the association of the Latin American Endodontic Association, SELA, we are going to have this monthly gathering to each other in which we are going to talk and discuss and criticize or critically appraise the publication in the hot topics in endodontic journals. Also, we are very happy to have internationally renowned endodontists with us, Professor Talal Al-Nahlawi, Professor Imad About, and many of other professors from other non-Latin American countries that joined this gathering. So welcome and thank you very much for your support. So now I want to ask Professor Hugo to officially start the session. Professor Hugo, please. So you need to unmute yourself, Professor, for us to be able to hear you.
Okay. Okay,
Yep,
that's it.
now we can hear you.
Thank you. Well, thank you, Dr. Nekofar, and welcome everyone to this project that we are very excited to begin with today. I'm going to give a welcome speech first in Spanish for all of the Latin American assistants, and then I will do it in English, and then we will keep the English with the translation with the captions here, okay? Bueno, estimados colegas, amigos y compañeros de la Sociedad de Endodoncia Latinoamericana, es un gran honor para mí estar aquí con todos ustedes en el lanzamiento de este maravilloso proyecto del Club de Lectura de Artículos Científicos en Endodoncia. En primer lugar, quiero expresarles mi más sincero agradecimiento a todos los presentes por hacer el tiempo para estar presentes acá, en este momento tan significativo. Su dedicación y compromiso con la endodoncia son realmente inspiradores. Quiero dedicar un especial agradecimiento al doctor Mohamed Nekofar, el visionario detrás de esta brillante idea. Su pasión por la investigación y el deseo de fomentar el aprendizaje continuo a través de la lectura crítica han sido fundamentales para aterrizar esta iniciativa. Gracias, doctor Nekofar, por su compromiso con la excelencia y por guiarnos en este camino hacia la enriquecedora práctica de la investigación y publicación en endodoncia. La investigación es la piedra angular de nuestra profesión. No solo nos permite mejorar nuestras habilidades y conocimientos, sino que también nos brinda la oportunidad de contribuir al avance de nuestra disciplina. Publicar nuestros hallazgos y compartir nuestras experiencias es esencial para que todos podamos beneficiarnos y crecer juntos como comunidad científica. A través de este club, esperamos crear un espacio donde podamos explorar y discutir los últimos estudios, fortaleciendo así nuestras bases en la investigación y a su vez mejorando la calidad de las investigaciones y publicaciones que realizamos en nuestros países. Quiero también rendir homenaje al trabajo de nuestra junta directiva. Su esfuerzo incansable y su dedicación han hecho posible que este proyecto se convierta en una realidad. Gracias Gisela, Sheila, Iliana y Caro por su liderazgo y por ser un ejemplo de trabajo en equipo. Igualmente gracias al doctor Hugo Plasencia, que también ha estado apoyándonos desde un inicio. Finalmente, les invito a participar activamente en este club. Juntos podemos construir un entorno donde se fomente el aprendizaje y se impulse el crecimiento personal y profesional. Que este espacio se convierta en un lugar donde compartamos conocimiento, cultivemos ideas y trabajemos unidos por el futuro de nuestra especialidad. Espero ver a cada uno de ustedes involucrado en este proyecto y que juntos hagamos que este club de lectura un punto de encuentro fundamental para nuestra sociedad. Muchas gracias y Now I'm going to read in English, so everyone who doesn't speak Spanish can understand. Dear colleagues, friends, and fellow members of the Latin American Endodontic Society, it is a great honor for me to be here with all of you at the launch of this wonderful project, A Praise to Raise. First of all, I want to express my sincere gratitude to everyone present this morning and making the time to participate at this very significant event. Your dedication and commitment to endodontics are truly inspiring. I want to dedicate a special thank you to Dr. Mohamed Nekufar, the visionary behind this brilliant idea. His passion for research and desire to promote continuous education through critical reading have been instrumental in landing this initiative. Thank you, Dr. Nekufar, for your commitment to excellence and for guiding us on this path towards the enriching practice of research and publication in endodontics. Research is the cornerstone of our profession. It not only allows us to improve our skills and knowledge, but also give us the opportunity to contribute to the advancement of our discipline. Publishing our findings and sharing our experiences is essential so that we can all benefit and grow together as a scientific community. Through this journal club, we hope to create a space where we can explore and discuss the latest studies, strengthening our foundations in research and therefore improving the quality of research and publications we carry out in our countries. I would also like to pay tribute to the work of my directive board. Their tireless efforts and dedication have made it possible for this project to become a reality. Thank you, Isela, Sheila, Liliana, and Caro, for your leadership and for being an example of teamwork. Finally, I invite you to participate in this project. Together, we can build an environment where learning, personal and professional growth is encouraged. May this space become a place where we share knowledge, cultivate ideas, and work together for the future of our specialty. I hope to see each of you involved in this project and that together we make this journal club a fundamental meeting point for our society. Thank you very much. And to begin with the program for today, I would like to also introduce to our first guest of this club, Professor Nessrin Taha. Dr. Taha is a professor in endodontics and coordinator in the postgraduate endodontic program at JOST and maintains a part-time private practice limited to endodontics. She attained her BDS from JOST, then pursued her postgraduate studies at the University of Melbourne, Australia, where she obtained a graduate diploma in endodontics, a clinical doctorate in endodontics, and a PhD. She is a member of the Royal College of Ireland, a fellow of the Royal Australasian College of Dental Surgeons in General Dentistry, and a fellow in the special field of endodontics. She is former Vice Dean, Director of the Dental Teaching Clinics, Director of the Postgraduate Clinics, and Head of the Department of Conservative Dentistry at JOST. She is also member and former chair of the Scientific Committee of the Jordanian Board of Endodontics and a member of the Research Committee of the Asia Pacific Endodontic Confederation. She published 45 research papers and clinical trials. Her publication received the Best Clinical Research Paper honorary mention in the JOE 2024 awards and top cited article in the IEG in 2023. She delivered 35 invited lectures nationally and internationally, invited speaker on vidal pulp therapy, dental trauma, and regenerative endodontics by the AAE, ESE, IADR, IFEA, and IAPD. She serves as a reviewer for 15 international journals, member of the advisory board of the Journal of Endodontics, editorial board of the International Endodontic Journal, Saudi Endodontic Journal, and BMC Oral Health. Co-authored 2 book chapters on vital pulp therapy in Principles and Practice in Endodontics by Mahmoud Torabinayat, and Biodentin book by Imad About. Received several international awards, including Sutherland Prize from the Royal Australasian College and Victorian Women Dentist Awards. So, Dr. Taha, we are very honored to have you here with us and this first session of this wonderful project. And we really appreciate your kindness and willingness of being here and presenting for us your experiences in your recent publication. We appreciate it very much. And I will give the word back to Dr. Nikofar so he can moderate and start with this session. Thank you, everyone, and see you later.
Thank you very much. Thank you very much indeed for this wonderful introduction and welcome. This is also very exciting for all of us, but I want actually to go quickly to the main part. But before that, I want to ask Professor Gisela to have his welcome talk as well. Gisela, please. Is Gisela there or disconnected maybe? Okay, maybe, okay, he's not there. I think she is there because I can see, yeah, I asked her to start actually.
He is not connected, doctor.
Okay, maybe she is disconnected. So let's start actually by asking Dr. Nessrin Taha if she wants actually to have a welcome talk first, and then I will share the presentation about this topic. Nessrin, please go ahead.
Hi, just to save time, I just briefly want to say hello to everyone and thanks for the invitation, the nice introduction, and for organizing this for this gathering. So I'm ready to start.
Okay, great. So let's. I think I can see now. Dr. Gisela is connected. Gisela, if you are able to say your hello to everybody, I like actually to start this session by your welcome.
Hello, thank you everybody to be here. Thank you, Dr. Nekofar, Hugo, for this opportunity to share with all the people who love endodontics. Thank you, Dr. Taha, to be with us. And hello, everybody.
Thank you very much. You are very energetic, very inspiring, and all of this happened because of your motivation. Thank you very much. By the way, this work actually is under the activity named Appraise to Raise, because in which our plan is actually to do critical appraisal. It start actually, the first session start by Dr. Venkatesh Babu at the time that you can see here, and then continued every month with the collaboration with Asian Pacific Endodontic Confederation. In the previous session, which was 27 sessions, and you can see now the topics and the name of the authors and the moderator, the main thing was to invite the first author or the corresponding author of the publication to join us, and we, without any hesitation, ask our questions, because in science there is no hesitation, and we are not formal. In science, we should be completely actually harsh, even if I say harsh, and ask our questions directly from the authors and critically appraise them. Because as we can see in the publication, there are a lot of drawbacks and there are a lot of problems, and finding a proper and a very well-written publication based on a well-organized research is sometimes very difficult. Therefore, we need actually to know how to critically appraise the articles as well. What we used to do, we used to ask our postgraduate student to present the article and also to practice the critical appraisal. If our colleagues in Latin American countries decide to carry on like that, I personally prefer to do so. Otherwise, I will do it myself or ask other professors and other colleagues to help me in each different sessions to do this particular activity, which is appraisal. But when we do appraisal, it is important to know what should we do. So before I go to the actually the publication, an article by Professor Taha, I'm going actually to give a quick list of what we are going to do during the appraisal. So first of all, assessing the research question is very important, which we need to know the clarity and relevance of the questions, objectives of the research questions, and then we evaluate the study design. And obviously we look at the different types of the trial and if they are appropriate or not. So the design suitable for the research question or not is another activity that we should do. Then we analyze the methodology. Sometimes very, very meticulously, we look at the randomization and we look at the blindness. We look at the control group, which is very, very important for clinical trials. Sample size is very critical and one of the main challenge for our researchers and our authors. So we ask about the sample size and the way that they measure it. Then we check for the participants and patient inclusion criteria, baseline characteristics, and the groups that they designed for their study. So there are a lot of experts now in our meeting with us. When we are going to talk about Professor Taha article, which we already share with each other, we are going to discuss that as well. Then we examining the interventions. Are the interventions clearly described? And is it possible to reproduce them? Was there any issue with adherence to the interventions or not? It is another thing that we discussed. Then we look at the outcome, primary and secondary outcome, measurement, results, and then we look at that and we look at the statistical test. Obviously, the statistical significance is not enough, and we look at the clinical significance as well as statistical significance. We look at the confidence interval. Recently, there is a tendency in most of the journals and asking for report of confidence interval as well as other statistical analysis, because it believes that without that one, it is almost impossible to have enough idea about the statistical analysis. Then we look at the discussion part of the publication, and we look at the way of the writing, if the interpretation of the data is good or not, or justifying not or not. Then they should talk about the limitations for the study. Another big issue for the critical appraisal is bias, and the type of the bias, different type of the bias, that we need to know that very well and discuss that very well too, to make sure that is there any bias or not. Sometimes there is a big bias for funding sources, and we need to find out the conflict of interest and the funding sources, and the effect of funding sources on the result is also reported in the article. Then when we do this type of things, we look at the overall quality of the article, and we look at the clinical application of the article as well as other things. Talking about the bias, we look at the selection bias, allocation bias, funding bias, conflict of interest, publication bias, outcome reporting, data analysis bias, interpretation bias, author bias, and editorial bias. So if we look at the list of this bias, we need, if we want to talk just about how we do critical appraisal, maybe we need another workshop to talk about it sometimes later. So I will share this presentation with our students and all the participants if they like to share it with their students as well. And then we look at the reference, and it is important to make sure that the author referred to the bibliography of them is very, very important, and we need to make sure that the article cover all of this issue. So this is a general idea of why and how we do critical appraisal. So because actually we have very important scientists with us in this meeting, I want actually to use this opportunity to ask Professor Imad about to give us an idea in general about the critical appraisal and the list that I showed here. Professor Imad, please have a quick talk about the first introduction. Please unmute yourself and tell us your idea about the key steps in critical appraisal.
Okay, thank you very much. I was not prepared to interfere in any way in this session today, but
You're not interfering, you are helping us. Thank you.
The introduction is really very nice. And being associate editor of a journal that you know, Clinical Oral Investigations, I see the bias and the difficulties with, I would say, most of the papers that we receive, and sometimes, and most of the time, most of the papers that are published. So basically, many aspects are just skipped, not highlighted, not indicated, not focused on. This session is related to a kind of work that I know. Nessrin Taha is one I know. The quality of work is a quality of work I know. So this is what I would say, but I will let you judge the kind of good work and good type of presentations. Although even any good work can be criticized, mine's as first. However, in my idea, this is the type of introduction that should be discussed and highlighted before any paper is submitted, because this is the criteria that should be considered. What is the idea? What is the protocol? How it can be conducted? Can we repeat it? And all the aspects that you have highlighted. Unfortunately, this is not the case. And when I say this is not the case, not in a single journal or in two journals, but in the major part of the journals. And sometimes also even these aspects, we can have an oversight, they skip our minds and we don't see them because that highly depends on the type of reviewer and the sensitivity of the reviewer we have. So sometimes the reviewers don't see them. Sometimes also the editor is not completely in his field, and some aspects, they just escape our awareness and the way we look at the things. So I think that for all the young students, dentists, PhDs, and postdocs, this is the type of presentation that should be done in all institutions, in all organizations, because this is really what we need. Just to give you an idea, in the major part of the high-level journals, about not only in clinic, but also in basic science, about 80% of the papers are rejected without review. That gives you an idea about the quality of the work that can be submitted. And among these, some are still rejected and some are not well conducted. And I've seen some papers published a long time ago and recently where the quality is not met. But anyway, once this is published, you can do nothing about that. Just to conclude, I think this is an excellent introduction, and I think this has to be the introduction before submitting any paper, whether in clinic or in science. Thank you.
Thank you. Thank you very much, Professor, about very informative comment. And I want again to emphasize that for the colleagues that they want to have the simultaneous translation by the caption, they can go underneath and select the CC on the right side, click on the arrow, and then select the language that they want to have the caption if they like to have caption in other language rather than English. So let's now go by having this initiation to one of the recent publication, where this is about the outcome and prognostic factors for partial and full pulpotomy in the management of spontaneous symptomatic pulpitis in carious mature permanent teeth, a randomized clinical trial. This article is published in Journal of Endodontics by one of the scientists and the group leader of the endodontic research around the world, Professor Nessrin Taha. And if you want actually to communicate directly with her, you can see her email here. So first of all, let's quickly have a look to the abstract of the article. The aim of this research was to compare the outcome and prognostic factor of these different modalities. And the design was a double-blind randomized clinical trial, and the number of patients that they have seen was 299 in partial pulpotomy, 101 in full pulpotomy. Procedure was actually done by one of the postgraduate students, so it was just done by one clinician. And then intraoperative hemostasis achieved with 2% 5 sodium hypochlorite and neoputty used as the capping material. And they look at the outcome after 1 week follow-up and for the pain relief, and the 6 months and then 12 months. And then when they look at that, they find it out 196 of 200 patients reported pain relief. 6 months follow-up, they had 6 failures in partial pulpotomy and 1 in full pulpotomy. And after 12 months, it changed. The success rate of full pulpotomy was around 98%. The other one was 84%. And the key findings of this publication is full pulpotomy had higher success rates. Rapid hemostasis is critical, especially in partial pulpotomy. And for the conclusion, they conclude that full pulpotomy is more effective technique in comparison to partial pulpotomy. So if we look at the introduction in terms of the critical appraisal, and because there are a student here with us and they want actually to learn about how to write an article, when we critically appraise an article, we look at the way that the author sets the stage for the study. So I should say that this article was fantastic in terms of explanation of the stage, that we know the need for more evidence is very important. And in terms of the new idea of looking at the pulpitis, they also make a very good literature review, and then they justify their own study by pointing out the lack of direct comparison in the literature about these two types of treatment modalities. So whenever we want to write something, we need to try to show and justify the reason that we did this study. In this particular article, the authors did a great job. The introduction also begins by highlighting the challenge of managing symptomatic pulpitis in mature permanent teeth, which we know that symptomatic pulpitis has a spontaneous lingering pain and severe pain, and it needs actually a quick and effective treatment to preserve the tooth vitality. And if you leave it, it ends up to necrosis. Traditional, or let's say conventional treatment for symptomatic pulpitis is full pulpotomy and root canal therapy. However, when we look at the growing trend in the world, we will find it out that there is a tendency, a huge tendency for more conservative treatment, like partial pulpotomy, which involves the removal of only some part of the pulp tissue and keep the vitality of the pulp tissue. So now it is time for question from Professor Nessrin Taha. The first question that I want actually to raise, and I'm also waiting for all participants, if they have any questions so far about the introduction, please just virtually raise their hand, turn on the microphone and talk. So the question is that if we consider the worst outcome of pulpotomy, which we know it may have some not a favorable outcome. So, and on the other hand, you mentioned in the introduction that there is a growing interest in conservative treatment, like doing vital pulp treatment, pulpotomy, and other modalities. What are the potential long-term consequences or risk associated with pulpotomy compared to conventional root canal treatment? What do you think, Nessrin? Nessrin, we cannot hear you. Please unmute yourself.
Yeah, I wasn't able to unmute. Yeah, thank you for the question. I don't think that there are any potential long-term consequences for full pulpotomy if the tooth is adequately restored. Because if there is any failure, it's most likely to be related to failure in accurately diagnosing the state of the pulp, which will lead to persistence of pain and immediate failures. But late failures after full pulpotomy are not actually common. And if they are there, they are mostly related to restorative issues like fracture of the restoration, recurrent caries, or leakage. So I think if the tooth is appropriately restored, it's going to have equal success rate to conventional root canal therapy. Some authors or audience always raise the question, is calcification a complication after full pulpotomy? Considering 16 years of research on vital pulp therapy and performing vital pulp therapy by myself and by my students, we have not witnessed any obliterated canals after full pulpotomy. Immediate failures or short-term failures after 6 months, they are easily manageable under magnification. And recently, I have been asking some patients for consent to take CBCT of teeth after long-term follow-up up to 10 and 13 years of full pulpotomy, and I could prove that canals are patent. And if there is any calcification, it's limited, like it's a limited intracanal at a certain level, for example, mid of the root. But then after that, the canal is patent. So in case RCT is needed, I think it's going to be manageable. And I hope to see more publications on this with long-term follow-up and CBCT evaluation, because what you can see as an obliterated or narrowed canal on a conventional 2D radiograph is not actually reproduced on a CBCT evaluation.
Thank you very much. What about the restoration? Because in your article, that one of the images that I shared, I have seen that sometimes we have a complicated restoration, such as a crown or an onlay, mesiodistal and occlusal restoration, something like that. So when we have a complicated restoration, the possibility or the chance of more leakage may be there as well. So what do you think about that? Has it got any effect on the outcome, or maybe in the future study we need to evaluate the different type of the restoration and the effect of the different type of the coronal restoration on the outcome? What do you think?
But particularly in this study, we were doing like intraoperative assessment of the remaining tooth structure after performing pulpotomy, looking at the remaining cusp thickness, the buccal and lingual cusp. And if we think that the tooth is weak, we had a prosthodontist where we would refer the cases for crowns or onlays. But you know, most of our patients, they don't have any insurance. And if they have to pay for occlusal coverage, they cannot afford it, because pulpotomy and the composite restoration was offered for free. So some patients will go for crowns, others they cannot, and they just accept the composite as it is. But with long-term follow-up, I could see lots of fractured restorations that some of them could be repaired, others they cannot. They need an onlay or a crown. It's only when we think that the tooth requires a post that we can exclude vital pulp therapy. But if a tooth can be restored with a core and crown, it's not a contraindication. And one of my favorite cases, 13 years follow-up after full pulpotomy, the patient had a crown after 3 years. And he is definitely happy with it, complete normal area, CBCT evaluation showing patency of the canal. He even favored it to a contralateral implant in the same patient. So it might be interesting to compare the patient satisfaction after vital pulp therapy and crown compared to implants or RCT. But I'm a strong believer, as you know, in vital pulp therapy. It's not a bias. It's just that I witnessed success. And if anyone has a doubt, we need to adopt vital pulp therapy so that we get more studies, larger follow-up, and more evidence to convince practitioners.
So in all, you believe that the type of restoration may not have any correlation with the outcome, the favorable outcome or not. So I mean, if we have a very simple restoration, maybe it has some effect on the outcome. What do you think?
A simple restoration, of course, is better because it means more remaining tooth structure. So if that restoration is intact, we are not worried about new leakage or we are not worried about tooth fracture. That will necessitate interruption of our vital pulp therapy procedure just for sake of restorative options. But in case that there is more than moderate loss of tooth structure, we have to organize coronal coverage for better longevity. That's definite. And I could see most failures I'm having with long-term follow-up, they are related to the type of the restoration, that it was a direct restoration, that it does not survive beyond 5 years. We get fractures that cannot be repaired unless we enter the canal.
Okay, and you recommend actually complicated restoration of on a tooth that you have done the full pulpotomy as a permanent treatment. Do you, in comparison to root canal treatment?
Yes, of course. Why not? Because the aim was to remain to keep vitality of the radicular portion, and we kept it, and we have to maintain this success by protection of the coronal tooth structure by a crown or an onlay or an inlay.
I am sure actually there are a lot of questions about this. So I want actually to see if there is any raised hand. I can see Dr. Talal. Do you want to add your comment or your question? Please go ahead. But unmute yourself, please.
Actually, very nice topic. My regards to Professor Nessrin. I'm always enjoying reading her articles, and also I'm enjoying being with you all here. With this, I was here from the very beginning, since the start of Journal Club. So we are enjoying. It's a very good opportunity. But let me elaborate on this really sensitive point on final restoration. I totally agree with Professor Nessrin that we need to cover the tooth in order to protect what we have done to prevent the micro leakage. But unfortunately, let's speak frankly, we have a lot of, if not done properly, especially for the coverage of the tooth, if not done like IDS, immediate dentin sealing, proper temporarization between the sessions, unfortunately, exposure of dentin may irritate more and more, especially in the cases of partial pulpotomy, so maybe will interfere. And I believe this was the point of view you want to emphasize, Professor Nikofar. We need also to emphasize that as well as we believe in vital pulp therapy, and me myself, I have long recalls about 12 to 13 years old, and I believe also in vital pulp therapy. But also I have a concern regarding whom is going to do the final restoration, and to pay attention not to add an irritant. So we need to keep in our mind sometimes failure will come from the irritation, from iatrogenic effects coming from the final restoration because we are doing a sensitive treatment. So I just want to elaborate, emphasize about the importance of doing IDS, immediate dentin sealing, proper temporarization, waiting for the lab in order to bring the overlay, for example, in order not to affect what we have done for the vital pulp therapy.
Yes,
Thank you very much, Professor Talal. Professor Arshad.
Yeah. The permanent restoration actually should be placed by the same practitioner who performed the vital pulp therapy. I have seen cases that have been ruined and ended with failure because of leakage, as you said, from inappropriate crown preparation, even performed by prosthodontists. So you can still see these cases. It's similar to any root filled tooth, so it's not special to VPT. But as you said, the direct restoration should be placed by the endodontist or by the general practitioner, and good immediate sealing is ensured before referral for a full coverage restoration.
Thank you. Professor Arshad, please go ahead and have your comment.
Okay, am I audible to everybody?
Yeah, please introduce
Can you hear me?
yourself. Yes, we can hear you.
Thank you very much. Okay, my name is Professor Arshad Hassan. I'm from Pakistan, so greetings from Pakistan. First of all, I would like to thank Professor Nikofar for restarting this very important activity, an important global activity, I would rather say, that connects everyone from the region and beyond. So it's a wonderful initiative, and really thank Professor Nikofar for restarting it, taking precious time from his schedule. The second thing that I would like to congratulate Professor Nessrin on publishing this wonderful paper, and it's an excellent paper. I couldn't go through the whole paper. I just read the abstract, and I was really amazed by the results. I'm really happy that you've come across such a big pool of patients. In my opinion, the strength of this paper is the sample size. I've seen papers on merely 20-30 patients. You have 200 patients. Wow, that's just amazing, mind-blowing, really amazing. Great job. So I just have one question from the methodology part, and then I have just one comment about the paper. So in the methodology, if you look at the methodology, I just have one question. The evaluation criteria and follow-up. So here you say that the clinical success criteria included the absence of pain and discomfort, and this is just for me to understand the paper, and it's not a criticism or critique. So a positive response to cold testing in teeth that received partial pulpotomy, and then there was nothing about the full pulpotomy group. Is that correct?
No, there is full pulpotomy group. No, if you read through the manuscript's body, you will see evaluation criteria for full pulpotomy, but the special case goes for partial pulpotomy because you expect there should be a positive response to cold since it's partial cutting. If at any time of follow-up there is lack of symptoms and coupled with lack of response, it means the tooth is dead, necrotic. So we cannot call it success. We may call it functional, but not success. While in full pulpotomy, the evaluation criteria will include absence of symptoms, clinical signs of failures, and radiographic normalcy, but do not expect a positive cold response because of the depth of the calcium silicate material that is placed in the pulp chamber. In our research, we never had any positive response in teeth treated with full pulpotomy in response to cold testing.
Oh, my apologies. I did not read the paper through. My apologies for that. The other thing that I would like to make a comment on, just taking your concept a little bit further, because from what I can see is for the full pulpotomy group, you have made the conventional access, because this is the era of minimally invasive endodontics, and I'm a bit of fan of minimally invasive endodontics. So what is your thought about if you go for a little bit of a minimally invasive access or a caries-driven access, and then go for a full pulpotomy procedure? What are your thoughts on that?
It is actually a caries-driven access because we initially, also if you read through the manuscript, you will see that it was non-selective caries removal, which means entire caries was first removed completely with the aid of caries detector dye. Pulp exposure was confirmed, and then after that, complete deroofing. I mean, you cannot combine, pulpotomy is a minimally invasive procedure compared to RCT, but you cannot perform it through like a constricted access. You can perform partial pulpotomy, but for full pulpotomy, from definition, it has to be complete deroofing of the pulp chamber.
Okay, thank you very much.
Okay.
Let's move on a little, and then we go back to the questions. So when we look at the introduction, we talk about the symptomatic pulpitis management. Historically, the tests with symptomatic pulpitis were often actually treated by root canal treatment, but the problem was the terminology. So irreversible pulpitis, now it actually changed to a spontaneous symptomatic pulpitis. So now it actually helps for more understanding, because when we say irreversible disease, that practitioner doesn't like actually to do vital pulp treatment. But when we say spontaneous symptomatic pulpitis, it actually helps for doing this type of treatment. So for partial pulpotomy, it involves removing of 2 to 3 millimeters of coronal pulp tissue at the exposure site and preserve more tooth structure in comparison to full pulpotomy, because full pulpotomy involves removal of the entire pulp. But in the introduction, the authors mentioned that there is not enough evidence to look at this. So this article is very important, and then they justify doing their research because of that. So the primary objective of this research is to compare the clinical and radiographic outcome. And also they want to analyze the prognostic factor, as we already mentioned: age, gender, tooth type, location of the tooth, time of hemostasis, that we discuss more about it, that may influence, they have some influence on the outcome. And the hypothesis was there is no difference in the clinical and radiographic outcome between these two treatment modalities in management of the spontaneous symptomatic pulpitis. So by looking at this part of the introduction, we also should know that the study actually prepared and tried to fill a gap in the knowledge. So they also addressed to the novelty of this study. That is also very important if you want to get an acceptance, even in very difficult journals like the one that Professor Imad about is here, clinical oral investigation, which is sometimes a nightmare for us to have a publication in that, although I'm happy that recently I had one. But you need actually to write each part of your article very, very delicately. So when we look at that, this article, the introduction of this article was very, very well organized. Thank you very much, Nessrin, and congratulations for that. By the way, despite the potential benefits of partial pulpotomy, such as preserving more of the tooth's natural structure, we don't have enough evidence to say that pulpotomy is better than a partial pulpotomy or not. And also, what we have from the previous study, as they mentioned in the introduction, is varying success rate for partial pulpotomy depending on factors like health of the remaining pulp tissue and the ability to control bleeding during the procedure. And it was the only things that in the previous study they mentioned that there is evidence about it. So if we look at the appraisal of the introduction, because I already covered the introduction, as I mentioned, we should find it out, is the clarity and relevance, and also does the trial aim to address a specific important clinical question or not? My answer to this is yes, the research question is clearly stated. And the study aims to compare the clinical and radiographic outcome of partial versus full pulpotomy in the management of mature permanent teeth. Additionally, it seeks to identify prognostic factor that might influence the success of this treatment, and this clarity is evident from the objectives and hypotheses outlined in the study. So the answer to the first question for the appraisal is yes, the research question and the relevance is very good. So the research question is clinically relevant because it already addressed a very important issue. And also it has some effect and influence and direct influence on our clinical decision-making, as we already discussed that one. And also it may have some potential for the future guideline, because clinical trial, when they're very well organized and when they cover everything, they are going actually to end up in guidelines and meta-analysis if they did everything very, very precisely. So now it's time to go to the second section of the article, patient selection and methodology. First of all, it's important to look at that. We don't mention material and methods because it is a clinical trial. When we write a clinical trial, the methodology of writing now is changed. We should mention patient selection and methods, not materials and methods. So study design. Study design, as we already know, is a double-blind study where both the patient and evaluator will be blinded. Be very careful because we are going now to ask Nessrin another important question. The second part is the operator could not be blinded due to the nature of this procedure, because obviously whenever the operator wants to do pulpotomy, full or partial, he knows what he wants to do. So the question from Nessrin now is, Nessrin, do you think it may be a part of the weakness of your study that you couldn't actually blind the operator? Obviously, it is impossible to do that, but maybe some of our participants may have some suggestion for blindness of that part. Let's see what we will receive from them. But what do you think? Can it be a part of the bias or something that the operator knows about full pulpotomy against partial pulpotomy? It may have some effect on their decision. What do you think?
I think we did the best that could be done in this particular case because the operator was blinded until complete caries removal. He was blinded in terms of preoperative pain levels at the start when we evaluated.
Can I stop you? I want participants to listen very carefully because this is very important. The blindness, sometimes when we cannot do complete blindness, we should try our best actually for this. But can you repeat, how do you select your patient and also talk a little more about the block?
Yeah, so at the time of evaluation, it's not the operator who was involved in the recruitment. It's just a general dentist at the initial treatment unit. He just refers upon my request any patient coming complaining of severe or strong spontaneous pain in his tooth for evaluation for inclusion in our criteria. So I evaluate. So the operator is not involved in selecting the patient. So that eliminates some part of bias because if you think, oh, this pain is moderate, it might be successful with partial pulpotomy. Oh, this is very severe, I will put it in full pulpotomy. So this introduced bias. So we eliminated this aspect. Second aspect, Carious excavation was completed before he knows the randomization. So all cases were treated similarly. Carious detector dye, complete Carious removal, pulp was exposed. Then she was not, the operator, she was not involved in the randomization. The randomization sequence was done by my co-researcher, Dr. Imran Zain Al-Abidin from Malaysia. So he is like thousands of miles away. And his brother also helped us because he's a statistician. He formulated the block technique. He offered 6 or 8 blocks, but I wanted like the highest strength for randomization. So he advised the blocks of 8, and I was emailed the Excel sheet. And I would choose, I looked at the codes, I place it in the envelope. So the operator is not involved in this procedure at all. It's only at the time of performing the partial or full pulpotomy that she was informed that this case is partial pulpotomy. So we maximized blinding of the operator as much as we can. And there is no other way of doing it. We also eliminated bias, like for cases when a partial pulpotomy was done and we could not achieve hemostasis, we completely excluded that case. So it did not go into the arm of full pulpotomy. So RCT was done. And similarly in full pulpotomy, if no hemostasis could be achieved, then RCT immediately. We did not attempt any further removal inside the canals. So yeah, that was blinding.
That's very, very informative. I think for our young fellows that they want to actually carry on doing some studies like that, that is amazing to find it out, the methodology that they should follow for such a thing. Amazing. Congratulations. It needs
You know,
actually
Dr.
both of
Gopal,
hardware. Yes, yes.
Sometimes we can add all these details, but because of the word limits of the manuscript, you cannot insert everything. So you add the details and you end up cutting it. It's only when the paper comes back with a revision that sometimes you can add more details on these aspects, but otherwise you cannot show it.
Yeah, that's great. Thank you very much. Is there any question specifically about randomization, concealment, anything related to patient selection? Please go ahead. Any of our colleagues, any of our participants, if you like actually to add any comment or ask any question about the methodology, please go ahead. Otherwise, I'm going to carry on. Okay, so far so good. So I have another question here about the restoration, because you already mentioned that you select the cases that they were restorable with direct restoration. Do you think that can be another source for the bias or not?
But I think maybe I misused the term direct. I did not mean direct as like in the clinic. The exclusion was only based on the need for intraradicular retention, which is listed in table 1, the need for a post. But if the case needed simple crown coverage or only, actually it was included.
Okay, yeah, because we call them also direct restoration. So when we say direct restoration, it includes only and all of them. Very good. Okay, let's move on. So the clinical procedure, obviously we already talked about that, but the clinical procedure done by one operator, a single graduate student, and then for the calibration also he or she conducted a non-study participants before the trial began, and then they did local anesthetics and then Carious removal and then hemostasis. We will talk about the control of bleeding now. And then non-selective Carious removal was performed using a Carious detector dye. And after that, when they confirm pulp exposure under magnification, the pulp rinsed with 2.5% sodium hypochlorite for the sake of hemostasis. And after the achievement of that, it was to 4 minutes and could control it in less than 4 minutes. They actually select the case for partial or full pulpotomy. If bleeding could not be controlled, the case was excluded and root canal treatment was initiated. So now, yes?
Because hemostasis was up to 8 minutes, 4 attempts of 2 minutes. So 2 by 4 is 8.
I understand. Thank you very much. So it was my mistake.
I think it's just...
I shouldn't have any mistake. Oh my God. I read your article 10 times. Believe me, 10 times. More.
I think you have chosen the critical. It's 2, 4, 6, and 8 minutes. So
that's
2 minutes application, repeated 4 times.
Understand. So the repetition is 4 times. Thank you. That's great. So see, when we read an article and when we read it even 10 times, we may understand something completely wrongly. So thank you very much. So procedural details. Partial pulpotomy, 2 to 3 millimeters of pulp tissue was amputated and hemostasis was confirmed. In full pulpotomy, the entire coronal part was amputated to the
I can't hear you, Dr. Nekofar.
Dr. Nekofar is lost?
Yes.
Yes. Professor Taha, I am Hugo from Mexico. I want to do a question while Dr. Nekofar is come back. Dr. Juan Carlos Paz from Mexico have a question. Is here. Since we cannot clinically assess pulp sensitivity, how can we ensure the complete pulpotomy treatment is functioning effectively? This is particularly important in cases where the treatment was not performed by us and the tooth will require a restoration replacement.
I didn't quite understand the question. Can you please repeat?
Yes. Since we cannot clinically assess pulse sensitivity, how can we ensure the complete pulpotomy treatment is functioning effectively? This is particularly important in cases where the treatment was not performed by us and the tooth will require a restoration replacement.
Do you mean like he's receiving a referred case where there appears to be a pulpotomy and then you are not sure if it was really a pulpotomy or mummification and all the procedure, for example?
Yes, I understood.
Yeah, I think the only way is that you ask the patient if he's aware of what treatment was performed on his tooth, or if you can get in contact with the previous dentist. Otherwise, you will assume it's an improper restoration that was placed in the pulp chamber, and you will initiate RCT probably unless you find bleeding tissues, and then you do place a calcium silicate material and restore again.
Thank you, Professor.
So yeah, there is no way that you will get a cold test response in full pulpotomy.
Okay. About this manuscript, Professor Taha, one of the most striking aspects of this manuscript was the limited number of dropouts. Only 4 cases out of the 200 originally included. What strategy did you use to minimize this situation?
Yes, I think the operator was very nice. Shuruk, she could communicate very well with her patients, and she did extra service for them by agreeing to participate in the study. We will treat extra teeth, we will organize referrals and treatment and so on. Also, during recruitment, we always ask about the place of residence or work so that we can track our patients. We take 2 phone numbers, we take social media contacts, and next of kin, and all these contribute to the high recall rate. I have learned a lot because my first clinical trial started in 2010. It was a struggle to get patients to come for follow-up.